Hello everyone, welcome to the EPG Pathshala. I am Asha Banu, faculty with the Center for Health and Mental Health, School of Social Work, Tata Institute of Social Sciences. Right now we are going to look at the module on homelessness and mental health determinants. To introduce the module, I will go on to the course objectives. To offer students a glimpse into the nature of mental health services in India. The second course objective is to enable students understand concepts of structural barriers and structural violence, deprivation and ontological security, and its relationship with mental ill health and well-being. And the third objective, to discuss concepts of human rights in the context of homelessness and poor persons with mental ill health, and sensitize students to the diversity of conceptualization. To start with, it's very important to get an overview on the mental health status in the country. 150 million Indians suffer a mental health condition as per the source NHS 2016. Depression takes over cardiovascular diseases as the primary cause of mortality by 2020, and 10% prevalence of common mental disorders in Indian population, and every time there would be top 10 non-communicable diseases, communicable diseases listed out in the country, within which 2 of the common mental disorders are already in place. One is depression and other is anxiety related disorders. And feminization of poverty is increasing, which is a phenomena in the developing countries that plays a crucial role in increased prevalence of mental disorders among women. Feminization of poverty means more number of women becoming poor and lack resources for sustenance. Now with that overview, we have to see the pathways to care in terms of mental health in the Indian context. So when we see mental health care in India, primarily we have government hospitals and the private mental hospitals, and there are clinics run by private psychiatrists and the traditional healers. National Mental Health Program was launched in 1982 as the outcome of NIMHANS report on the inaccessibility of these existing facilities. When I am talking about government and private mental facilities, clinics and traditional healers, they are scattered and they are not available in all the contexts. India is such a diverse country where you have rural, tribal, urban, and even in the urban context, sometimes because of lack of awareness, people do not reach a mental health facility, but rather they would reach a traditional healer in urban contexts. Now let's see what are the objectives of National Mental Health Program. This is basically to ensure the availability and accessibility of minimum mental health care for all in the foreseeable future, particularly to the most vulnerable and underprivileged sections of the society. Here we can think of most vulnerable in terms of geographical, in terms of age, in terms of physical fitness, and it can be sexual minorities. The second is to encourage the application of mental health knowledge in general health care and in social development. That is how to try and take the mental health information and knowledge to the primary health care, and how general health practitioners can be trained into the psychiatric domain, and how this can play a major role in social development. The next objective is to promote community participation in the mental health service development and to stimulate efforts towards self-help in the community. Banyan is one organization which is working on the third objective, where community becomes a unit of intervention and how they are triggering multiple support systems within a particular context where people respond to the immediate mental health care needs. Now let's understand what DMHP is. DMHP is the District Mental Health Program, launched under the National Mental Health Program in 1996 to integrate mental health into the general health care. Basically, the idea is to decentralize treatment through District Mental Health Program. The goals of DMHP is to provide sustainable basic mental health services to the community and to integrate these services with other health services. Early detection and treatment of patients within the community. It is like this, that when we go to a rural context, people always think in terms of possession, people always think in terms of evil spirit, people always think in terms of black magic, and they live with that understanding and information and not reporting severe mental illness to the hospital. From our understanding, it looks like there is a misconception, but they are not reaching to a facility, but in reality they do not have a facility to reach to, and they do not have resources to reach to a tertiary health facility. So the goal, one of the goals of DMHP is how to promote early detection and treatment of patients within the community. So because of this, there would be one specialist who would be expected to visit the primary health care on a periodic basis to consult for mental health concerns in rural context. Next becomes reducing stigma attached towards mental illness through change of attitude and public education, and this is also a social worker's terrain where you can work on reducing stigma. When we work on community as an intervention, this definitely changes. People are much more aware, people get information on mental health and mental concerns, and when they start providing care, the stigma automatically reduces. Treatment and rehabilitation of mental patients discharged from the mental hospitals within the community. This is a greater challenge today, and particularly with regard to women who are discharged from mental hospitals, this is a challenge because there is lack of acceptance in the larger community. So how to work? There are TISS has a field action project which really works on this, where women who are showing signs of recovery are discharged from the hospital and they are rooted back into the community, and how the project works in terms of reintegrating them in the larger society and work towards their independent living. The next goal is shifting focus and reduce burden from mental hospitals. Take the burden from the hospital and how we can work towards hospital depopulation and moving them to the larger community. Now, the role of primary health centers in district mental health program. PHCs, as in the earlier slide I mentioned, they work towards identification through two ways. One, the general practitioner himself is trained in terms of basic psychiatric information and mental health knowledge. Two, a psychiatrist or a specialist visiting the PHC on a periodic basis. Treatment, referral and follow-up services for persons suffering from mental health issues. Two is by spreading awareness using IEC materials. While these are all the envisaged goals, oftentimes when we reach to the PHCs, we do not see IEC materials, and this is one area which is really in need of strengthening in the Indian context. Then third, in terms of staffing. So what is expected in DMHP in terms of staffing in PHCs? Expecting psychiatrists, clinical psychologists, psychiatric social workers, psychiatric nurse, program manager, case registry assistant and record keeper. But in reality, this staffing pattern doesn't exist in any of the DMHP at the PHC level. General physicians of district mental health program, PHCs to be trained to identify and treat common mental disorders and make referrals for those with severe mental disorders. So the general practitioners are trained and they are expected to refer them to the tertiary facility. While on paper it is very simple that the general practitioners would do a referral note, in practice it is really difficult because expecting a person who is on a everyday sustenance, who is fighting for his bread and butter on an everyday basis, making the person accompanied by a family member to visit a tertiary facility which is 180 kilometers away is definitely impossible. It is like putting burden on the family and the person. In 2008, Government of India expanded the purview of district mental health program to offer life skills education, counseling in schools, college counseling services, workplace stress management and suicide prevention services. While in certain places these are effective and these are functioning, not in all places it has picked up. If you look at DMHP, only 300 districts out of the 640 districts is operational across country. Now, quality of care in mental health settings. Several setbacks in every stage of DMHP implementation, such as Majority of the general practitioners were not trained enough to cater to mental health needs of the clients. Often we see that we go to a district level and we look at all the PHC doctors, they are not trained. From the university, often faculty members go in terms of doing capacity building programs for doctor, and their understanding of disability and mental illness would be very minimal. Pharmacotherapy and titration of different combination of psychiatric drugs and management of side effects were a challenge for general practitioners at the PHC level, which is also very important to consider. Any kind of negligence from the PHC doctor's side can result in disastrous impact on the client's well-being. Little supervision from the core DMHP team that restricted themselves to DMHP hospitals. This is the reality. While the document has prescribed measures to reach a wonderful goal in terms of promoting mental well-being in the community, but in reality these are the challenges that we see in terms of untrained people, in terms of medicines not available or general practitioners unable to use different combination of psychiatric drugs, and also added to this little supervision from the district mental health program core team, who do not periodically visit the PHCs to handhold the general practitioners. Time crunch. Doctors have only 3 minutes per patient. This is not the reality in PHCs, but it is also the reality in the outpatient departments in an urban context. Because the DMHP core team visits a particular place only once in a month or once in 2 months, and the patients would be lined up on the particular day, so the psychiatrist would not be able to give that much quality time to the individuals. Health system was discriminatory towards people from certain castes. So this is very much visible in certain contexts where there are certain caste people who would not be allowed to access the PHC, which is in the non-tribal location. Inadequate support staff to help identify common mental disorders or somatoform disorders. We can see this often when we go and work with the paraprofessionals in rural context. They often say, oh my God, we never knew. When we saw these person coming again and again complaining about chest pain, we almost thought it was the patient has gone crazy, but we never thought beyond. Rather than doing a referral, what often we did is we provided a B complex tablet, or we provided some tablet to shoo him away from the PHC, but not investing in terms of working on the mental health concerns. So we always realize that the health practitioners and the paraprofessionals are much more open to the training program. What limits them from doing is their lack of awareness and the helplessness in terms of what is to be done in such a context. Now, National Human Rights Commission NIMHANS report on mental institutions also is very important to understand, to set the tone for the content. This particular document has documented violation of basic human rights within the hospital. Diet that lacked nutritional value, 17 hours of wait between meals. In one of the modules we discussed about institutional settings and why it becomes a failure model, and why there is a shift towards deinstitutionalization movement, essentially because of such documents which exposed rights violations within institutional settings. And we have read in newspapers too number of times where organizations have exposed what's going on within, and organizations from the southern part as well as from the eastern part has exposed how women have been allowed to be without the clothes because the one set of clothes have gone for laundry. And we have even listened to narratives where the last meal of the day would be provided by 4:30 because the employees and the staff members have to leave the hospital by 5, and then the next day meal would be provided only by 9:30 a.m. and there is no clean water that would be given to them for drinking. And how the persons with mental illness who are in the institutional setting are given bath as groups, so these are all basic rights violations which have been documented. And also also in terms of infrastructure, colonial era rooms with minimal ventilation and light. So often when the documents is reflecting on change, the infrastructural change has not happened. It almost is structured for restricting the patients, and it almost looks like prison, and there is no ventilation and light. Men and women to bathe in open spaces and change uniforms only once in 2-3 days. Suicidal patients to sleep semi-naked. Unmodified electroconvulsive therapy, that means anesthesia would not be provided. Like on one hand, when the medical fraternity argues that ECT has its own value, while one can agree on that, but then often we see within hospital spaces the protocol to administer ECT has not been adhered to, and these are all given in the report in 1999. But even after decades, we do not see much progress within these institutional spaces, and the one reason for the poor quality of care would be often cited as understaffed with just psychiatrists and caregivers, and had many unfilled positions such as the posts of psychologists, social worker, nurses and counselors. Having said this, when we also interacted with the persons with mental illness who are residing as part of our work with them, majority of the women had cited that their interaction with the medical practitioners or the psychiatrist is very minimal. The interaction about their symptoms would be always between the caretakers and the doctors, and not between them and the psychiatrists. Now the next slide, we will look in terms of landmark incidents in care and protection of persons with mental illness. Airworthy tragedy which the entire world witnessed, where 26 patients died in a fire accident as they were chained to pillars, which was considered to be a human rights violation. Supreme Court took suo motu notice to the incident, and Sheila Barse versus Union of India and others, 1989, mentally ill persons with no criminal records were sent to jail with no access to mental health care. The other instance is the case Sheila Barse versus Union of India and others, 1989, where mentally ill persons with no criminal records were sent to jail with no access to mental health care. Supreme Court made it mandatory for persons with mental illness to be produced before a magistrate and referred to the nearest mental health care facility. While the provision is there, often we can find persons with mental illness landing up in prisons, or they would be landing up within the institutional setting beggar's home, which is for the homeless persons with mental illness, and they continue to detain under Prevention of Beggary Act 1952. The next slide is treatment gap. India's population is 1.2 billion, and out of which 67.2% live in rural areas, and 80% of Indians with a mental health need do not have access to treatment. 47 mental hospitals available in India in Tier 1 and Tier 2 cities only. Nationwide survey in 2002 brought out that for every 1 lakh population there are only 2 psychiatrists, which is like it's closer to 0, 1.5 clinical psychologists and 2 psychiatric social workers, and largely concentrated in cities. So now with this background information of how feminization of poverty, how the existing mental health care facilities is not being accessible, whatever has been envisaged by the DMHP is very ideal, but practically things are not happening the way it has to, and the existing mental health hospitals also are becoming spaces which are violating the rights of persons with mental illness. Having set this context, now it is important to look at the larger population, the 60 odd population who are in the rural context, who are living with who are living in deprivation and marginalization, and to connect why this poverty, mental health and homelessness nexus is becoming a persistent problem. Now let's try and understand what it means, what is a persistent problem. Complex multiple causes and consequences exist covering societal domains rooted to social structures in and institutions. If you would have listened to the module on social perspectives in mental health, it would have given an overview on what are the sociological underpinnings, and we would have listened to what is social causation. So this is one facet of that. Poverty exacerbates mental ill health. Poor neighborhood direct and indirect causes including mother's prenatal health, nutrition, housing status, racism and other forms of discrimination, caste, etc. are risk factors of schizophrenia by a study done by John Reed in 2010. So there is definitely a complex scenario that leads to mental illness. It's just not like a psychiatric condition, but there are multiple factors in societal domains that leads a person to illness. 3/4 of global burden of neuropsychiatric disorders are borne by the low and middle income countries. When we are talking about low and middle income countries, that also means that we do not have adequate resources to cope with the global burden of these neuropsychiatric disorders. Income inequality leads to a state of chronic stress. Then gender, poverty, caste nexus and feminizing poverty is something that needs to be discussed. Malnourished women and girl children drop out to take care of male siblings. On one hand, sitting in a urban location and in a metropolitan city, this might sound a decade backwards, but then it's the reality of many contexts. Students who go to Rajasthan for field work or even to the rural parts of Maharashtra, they come back and say how many girl children are dropping out of school to take care of their siblings, be it female or male, and also we can still see child marriages and how malnutrition passes from the mother to the child. A marriage at young age, getting married, malnutrition, anemia, passing on to the next generation. Girls drop out of school owing to poor menstrual hygiene. This is one of the factors that has been cited when there was a survey on why girls drop out of the school. It is also because of poor menstrual hygiene. Women are last to access health care when unwell. This is rooted into the culture of the Indian context. And while we talk about feminization of poverty, there is also something called feminization of caring, because in Indian context, when you look at caring and caregiving, primarily it is not primarily, all the studies when it looked at caregiving and mental illness or caregiving and elderly, the role is played by women. So easily we can call it as feminization of caring. Girls are married off before legal age, and there are social ills that are continuing to happen in the form of dowry and intimate partner violence. And 70% of Indians earn rupees 134 per day, and till today discrimination exists. Dalit children, the separateness is reinforced through seating arrangements in certain schools, which makes them to internalize stereotypes and live with low self-concept and esteem. Thus, in all these explanations provided for the context building, depression and anxiety is twice as prevalent amongst women when compared to men, and inordinately high among people living in poverty. So it's essential to look at the sociological and philosophical attributes, and it is important to reflect on one's disempowered status and impoverished internal locus of control through these attributes. So whatever has been explained, it is like the well-being is dynamic and it is governed by a complex factors all the time, which includes social and sociological circumstances and health, mental ill health, mental health and distress, and the life events and responses in the given context, pathology, social ecology, and genetic vulnerability. So there are a complex set of factors governing an individual's well-being in a given context, and as mental health social workers, it is important to understand, rather than looking at illness, it's important that the well-being or illness or distress is governed by varied processes, and while intervening we have to be very conscious of these domains. Talking about, having set this context, now we'll move towards homelessness in India. Census of India defines homeless person as someone who does not live in a census home, that is people sleeping in temple, mandaps, pipes, roadside platforms, etc. Census estimates from 2011 shows that 1.73 million are homeless in India. Homelessness is caused by a multitude of social factors. Poverty, unemployment, debt, disaster, political conflict and ill health, domestic violence or interaction of all aforementioned. Homelessness, it's isolated, visible to everyone but invisible to lawmakers, politicians and civil societies. And homeless population are vulnerable to violence, inhuman treatment and systemic exclusion. Now, particularly in Mumbai is a commercial capital and a cosmopolitan city, but oftentimes I always end with this challenging question by the student: what do we do with the person who is on the street and the person seems like he is mentally ill? What should I be doing with the person? Now there comes the challenge. We do not have much option other than taking the person to the beggars home nearby, or you take them and admit them to the mental health hospital as per the provision in the Mental Health Act. But then the element of choice comes in. Who is the person to decide? Is it the person who should be hospitalized or me as the individual? So there are many gray areas. Is there any transit care facility, open entry exit facility for persons with mental illness on the street, or the women who are sexually abused on the street? The answer is no. And oftentimes increasing number of women are on the streets are not because of multiple factors, but the major factor being family as an institution has failed them. If family as an institution has failed them, there is no possibility of reintegration with the families. Do we have adequate facilities and shelters for the women? We do not have. What we have is institutionalizing them either in mental hospitals or in beggars home facility. Now, Prevention of Beggary Act of 1952 criminalizes homelessness, leading to unlawful arrests and displacement of urban homeless. A homeless person with mental illness fares worse in an already hostile and exclusive climate. So, on the one hand, when penalizing poverty in itself is something not correct, now a homeless person with mental illness would also be detained within an already hostile and exclusive climate where there is no mental health care provision which is available within that particular context. Homelessness and mental illness. Homelessness, a collective failure of society in addressing issues related to poverty, stigma and discrimination, lack of access to care and poor awareness regarding treatment options. In the mental health context, often the organizations that are working on persons with mental illness always encounter this, that we have received a person from Calcutta, and people from Calcutta will say, we have received a person from Mumbai. Or if it is an organization that's working in Chennai, they find a person who has traveled all the way from Delhi to Chennai. Why it is happening? Because the family caregivers do not know what they have to do with the person with mental illness. Rather, they put them into a long distance train and forget about the family member, and thus the person reaches far off where they cannot get back into their to their respective families. So, this is a collective failure of society in addressing issues related to poverty, stigma, discrimination and also lack of provisions for families and persons with mental illness. Rather than blaming the families for abandonment, it is high time that we have to focus on creating provisions to support the families while they work and while they take care of the persons with mental illness. A result of complex interaction between structural barriers, isolation and nature of mental illness. Now, global trend, 25 to 30% of homeless population have at least one mental health concern because of the higher vulnerability. Homelessness causes mental illness and also it is vice versa. Like how we discussed both social causation and social selection, sometimes homelessness and the stress living with stress of living on the street results in mental illness, or because of their mental illness they have landed up on the street. Now let's look at mental health, homelessness and human rights. Individual victimization, highest risk factor for psychiatric illness, and particularly in the context of women. Women with mental health issues are at much higher risk of physical and sexual abuse, while others are prone to robbery, theft, threat with a weapon, and physical violence and sexual assault. A study reveals that 22% of women with schizophrenia reported that they were raped, with 2/3 being raped multiple times. If you look at human rights, there is a definite maltreatment of persons with mental health issues. Definitely we are compromising on the civil and the political liberties, and the urgent need to secure rights that empower clients to make their own choices, including rights to refuse treatment and promoting access to treatment who deserve to have the treatment. Now, physical health issues among the homeless persons with mental illness also is important to consider. Now, while I'm delivering, or when we use it, we often slip into homeless mentally ill, but then it is appropriate to use homeless persons with mental illness, because it's the emphasis that we always have to do persons with mental illness. Marked increase in death rates owing to poor diet, cardiovascular disease, HIV/AIDS, pneumonia, smoking and liver diseases is high among the homeless persons with mental illness. They also pose a higher risk of premature death owing to suicide and physical health problems. Now, when I'm reading this might sound new, but then when you actually start going on the streets and start witnessing homeless persons on the streets, you will understand how fragile they are, how many people are deprived of healthcare facility, and particularly when they have mental illness, the expectation of a caregiver to accompany the person, how it limits the person to access the healthcare for physical health, this would be very much visible to you. So that should be your exercise right now after looking at the slide, to see in terms of how do you view homeless population, rather than looking at them as just they are there, but now you have to look from a different lens in terms of what are the deprivations they are suffering, and when we are articulating a rights language, are we not violating the right to health care for a major segment of the population within the city who are coexisting with us. The Banyan, which is a leading organization in the country, has observed complex issues such as skin conditions, tuberculosis, HIV/AIDS, fractures, pregnancies, bruises, maggots, and skin lacerations. When they have rescued women from the streets, these are the common physical health problems the Banyan had to address alongside the mental health concerns. The other reasons include inadequate trained staff, poor reporting of physical health issues by persons with mental illness owing to compromised cognitive functions, social isolation and exclusion, and being paranoid and suspicion to access health care. So with this I conclude this module. The module tried to give an overview on the pathways to mental health care. It also gave an overview on the multiple determinants which leads to a persistent problem, and it also had given an understanding of the mental ill health poverty, the mental health poverty nexus, as well as the human rights violations that are going on, and what are the challenges that are faced by the homeless population with mental health concerns. Thank you.